Good afternoon to all my dear students. How are you all? So, today in ophthalmology we will be discussing lesions of visual pathway. Right? Okay. So, I chose this because this is one of the trickiest topics and many of you have a lot of doubts in it. So, I thought let me discuss this separately with you all, lesions of visual pathway. Chalo. When you say lesions of visual pathway, we will first start with understanding the pathway, right. So, let us look at this diagram here. So, we start with the two retina. You all know when you are making a pathway, left ka left, right ka right, first of all, no confusion, right. So, when you start making the pathway, this becomes your left retina, this is your optic nerve, then how it is crossing, going to the chiasma. After the chiasma is optic tract, isn't it? Then comes your lateral geniculate body, and these are the optic radiations. This is passing through the temporal lobe, one is passing through parietal lobe. Done? And this becomes your visual cortex. Now, what I want you all to pay attention to is the color coding. If you look at the color coding and see here, if we talk about this left retina, can you see the green part is your temporal, right. So, if you realize this temporal part of the left eye is not giving vision here, but it is giving vision to the opposite side. Now, this is what should be understandable, then only the whole thing is going to be clear to you all, right. And similarly, this if you look here, again the temporal of this and nasal of this is like this, and look at the color coding, now this is like this, right, in a W shape. So, what do you understand by this? That the coordinates of the retina and the visual field coordinates are opposite. So, what do we mean by this exactly? So, what we mean by this is that when you say coordinates are opposite, what do you mean by this? If I am saying that nasal fibers are gone, it is the temporal field which will go. If I am saying the temporal fibers are gone, it is the nasal field. Similarly, agar superior fibers jayenge, so inferior field effect, inferior fibers superior. This should be absolutely clear to you, then only you are able to understand the whole thing, right. Okay. So, now you know that, okay, let us then make this visual pathway ourselves as well, then only it is going to be clear. So, in my style will simplify it as this is your left retina, this is your right retina. Are we making it together? Please draw the diagram. We equally divide it into nasal and temporal field, nasal and temporal. Now, it is the nasal fibers that are going to decussate and temporal will not decussate. So, nasal fibers decussate and temporal will not. This is how we make it, right. So, this becomes your, what is this? Optic nerve. Then this is the chiasma, है ना, optic chiasma. Then comes your optic tract, isn't it? So, this becomes your optic tract. Then lateral geniculate body. Then there will be optic radiations as we learned, temporal and parietal, temporal and parietal. And then it is going to end in the visual cortex, we make like this. So, just for our simplification we can do this. So, this is chiasma, this is the tract, this is your lateral geniculate body, this is your optic radiations, this from the temporal lobe, this from the parietal lobe, and this becomes your visual cortex. Okay. So, one by one let us think together, we are talking about the lesions, right. So, we see the lesion number 1. Lesion number 1 is one sided, suppose I take all the left sided lesions as an example. So, lesion number 1 is one sided, your optic nerve is gone. So, if that sided left sided optic nerve, whole optic nerve is gone, then naturally what am I going to get? Then it will be ipsilateral blindness. So, एक तरफ की पूरी optic nerve गई, तो क्या होगा? Ipsilateral blindness, right. Okay. Then we talk about the next. Next what we see is chiasma. In chiasma, if the number 2 lesion says that the nasal fibers which are decussating, when this is gone, what will happen? As I just explained, there will be temporal field defect in both eye. Both eye nasal are gone. So, this time we are making a field defect here. So, if this is your left retinal field, visual field, and this is the right visual field, we are going to make the temporal field defect as something like this. What is this called? Both eye temporal gone. This is what is bitemporal hemianopia. This is your bitemporal hemianopia. Right? Now, what happens next? Next is your tract lesion. Let us see in the tract lesion what we have to learn. Tract lesion, suppose is number 3 lesion. What do you understand? Let us see here. One eye, right, if I am talking about the left sided lesion, the right side what is gone? Nasal fibers. Left side what is gone? Temporal fibers. So, what is the field defect? Naturally, left side will be the nasal field defect and right side will be temporal field defect. So, when there is a left sided lesion, and this shaded part is the defect and it is all on the right side. So, if there is a left sided lesion, you will get a right homonymous hemianopia, right. So, left sided lesion means right homonymous hemianopia. Okay? Okay, we come to the next. Next is your radiation lesion. When you talk about the radiation lesion, of course, we will be taking it one by one about the what will happen if the fibers passing through the parietal lobe are gone and temporal lobe. But overall, if you think in the posterior part of the radiation lesion, again the pattern is same, one eye temporal, one eye nasal, isn't it? So, it will be the same homonymous hemianopia whether I am talking about number 4 radiation lesion, and lastly even if I am talking about number 5, that is your number 5 is what? Your sorry. So, number 5 that is your cortical lesion, right. So, just 1 minute, let me see how you, yeah, I think this now it is visible. So, this is the cortical lesion. Again it will be homonymous hemianopia, right. So, and if it is a left sided lesion, you are always going to get a right sided homonymous hemianopia. So, this is the basic which should be first very clear to you, right. And once this is clear to you, then we can go further one by one and learn a little bit more detail about it. Okay, so, once you know this, kya pada? Very quickly we said that in chiasma it is bitemporal, but when you talk about tract, optic radiations and visual cortex, it is homonymous hemianopia. Okay? One eye nasal, one eye temporal. Homonymous means on the same side. So, that means the only lesions, now pay attention and you can note it down, the only lesions which are heteronymous are chiasmal lesions, isn't it? So, the only lesions that are heteronymous, these are chiasmal lesions. Can we note it down? The only lesions in the box, the only lesions that are heteronymous are chiasmal lesions. Keep this in mind. Okay. So, once this basic is absolutely clear to you all, we will go further. So, let us have a look first here, and of course, we are going to talk about details in the visual cortex lesion as well. Let us see one by one. Okay. Again, this is the figure which is very nicely showing you the same thing. This is again left sided lesions. So, the whole A is what? Whole nerve is gone, it is left total ipsilateral blindness. If it is B, it is bitemporal hemianopia because it is a central chiasmal lesion. If it is C, it is a tract. C is mainly, okay, C we will hold it, it is not ours, we will go to D first. So, you talk about D, here it is just trying to say that if temporal fibers are gone, you get a nasal hemianopia. Okay. Then next is your D. D is saying that again, if it is a left sided, I am getting a right homonymous hemianopia, right. Okay. One by one we will take further. First, once we are clear with this, next thing we will talk about is chiasmal lesions first. Okay. So, when you say chiasmal lesions, we have to learn that chiasmal lesions can be of 3 types. Okay. So, chiasmal lesions can be either, and now we are learning little further than what you have just studied. So, if the lesion is central, we learn that it is going to lead to bitemporal hemianopia. This is absolutely clear to all of you. Now, what will happen if the lesion is at the junction of the nerve and the chiasma? That is called anterior junction syndrome, and there is something which is called posterior junction syndrome. We will take one by one. Okay. Posterior junction syndrome. So, let us see What are the things you have to learn first in chiasma? So, chiasmal lesion, as you see, what field defect it is? देखो यहाँ पे नहीं है, यहाँ पे नहीं है. So, this is what is bitemporal hemianopia. This patient can see the nasal field is fine, but both eye temporal field is gone. So, this is a bitemporal hemianopia. ठीक है? Okay. So, we will say it is mainly कौन सा lesion? Central chiasmal lesion. It is a central chiasmal lesions. Right? Okay. We come to the next important thing. Look at this one. If you look at this slide, you see the lesion is at the junction of, what do you see? It is at the junction of nerve and chiasma. So, when this happens, what happens? One eye, either you get a central scotoma, as you can see in this case, or sometimes even complete blindness. So, this side nerve is gone, that side you will get central scotoma, but the chiasma, it is a junction of chiasma and the nerve. So, what about the chiasma part? So, understand here, this is a normal anatomy that the inferonasal fibers of one will first detour to the other side like this and then enter. This is what is called anterior Wilbran's knee. So, where was the lesion? Lesion was here. So, if the lesion is here, it is mainly not only causing optic nerve problem, but also damaging the Wilbran's knee, and because these fibers are inferonasal, you get just the opposite superiotemporal field defects. Okay. So, this is what you are getting, superiotemporal quadrantopia. So, this is also your exam question. Actually, this whole topic is a very important exam question. Many questions are asked from here. Okay. So, bitemporal hemianopia, homonymous hemianopia, everything is asked in all the exams. So, now what did you learn with me? Anterior junction syndrome is what? When the lesion is at the junction, what is happening? The anterior Wilbran's knee is affected, and therefore, apart from central scotoma on the eye where the nerve is gone, you are getting opposite side superiotemporal quadrantopia. Superiotemporal quadrantopia. ठीक है ना? I hope this is absolutely clear. Right? What is the other name of this condition? We can also call it junctional scotoma of trocar. Okay, trocar is the name of the person. So, junctional scotoma of trocar. And what is posterior junction is when, just remember it here, macular, only the macular fibers are affected. So, if I draw the field effect with you all here for the posterior junction, where the posterior junction syndrome, how will I draw this field? Let us do it together. Only the macular, but it has to be heteronymous. Okay. So, one this side and one this side, macular but heteronymous hemianopia, right. This is what is posterior junction syndrome in chiasmal lesions. Okay. What else we have to keep in mind? After this, let us not forget this slide, and this picture and anatomy should be absolutely clear to you. I hope you all know this is a cavernous sinus. We had learned 3, 4, 5 passing through the walls. The 6th nerve is through the body of the sinus along with this one. This is your internal carotid artery. Anyway, let us not deviate from the topic. This is your pituitary gland, and here is the optic chiasma, right. So, any pituitary adenomas, can you see it will be the inferior fibers which in the chiasma which will be affected first, right. So, keep in mind in pituitary adenomas, if the inferior fibers are first affected, it will be a superior quadrantopia first, and then it is going to progress down and later even involve this field. This is the direction, and of course, finally you will get a bitemporal hemianopia. So, you have to understand, if you revise an anatomy, you will understand this, that what we have to understand here, that craniopharyngiomas, pituitary adenomas and aneurysm, circle of Willis, these are again very important causes of chiasmal lesions. So, just remember, if you are talking about craniopharyngioma, it starts from inferior quadrantopia and then covers here. In case of pituitary, it is just the opposite. This is just one step little ahead I am teaching, because it is easy, you will know it. Little extra is always important to learn, right. Okay. So, once you know this one, and what is this showing you, that any central chiasmal lesions, keep in mind this is another important feature of central chiasmal lesions. And what is this? One eye up, one eye down. This is called seesaw nystagmus. Okay, so we will learn it as seesaw nystagmus. Okay. So, keep in mind this is a feature of central chiasmal lesion. So many things we have to learn, not only bitemporal hemianopia, we talked about anterior junction, posterior junction syndrome and about seesaw nystagmus. Okay. So, once you know this, we next talk about your tract lesion. हो गया ना? Chiasma, first ipsilateral, let's go back and think. So, the purpose of here is not for you to casually just listen to me, you have to learn along with me. You will learn everything if you are alert. So, if you go back to your diagram, we have already talked about number 1, we have talked about number 2 lesion. Now, we are coming to number 3, that is optic tract lesion. क्या पढ़ा है optic tract में? One eye temporal, one eye nasal. So, you are getting, if it is a left sided tract, you get right homonymous hemianopia. Suppose there was a right tract lesion, you would get a left homonymous hemianopia. What else you have to learn in tract lesion? Let us see. Okay, coming to the tract lesion, another very important thing, yeah, here we are, is apart from homonymous hemianopia, next important thing you will learn is vernix hemianopic pupil. What is hemianopic? Adha hai, adha nahi. Half is working, half is not. So, what is vernix hemianopic pupil and how do you explain it? Let us understand, it is very interesting, pay attention. Okay. So, when you say vernix hemianopic, vernix is of course a name, it is a type of defect where half of the pupil is working and half is not. कैसे होता है ये? What you do, you make the patient sit in a dark room, take a pencil torch, not a big torch, show the light from one direction. ठीक है? Suppose you show so that it is actually falling. Suppose my patient is in front of me, I have to test this vernix hemianopic. I take a pencil torch, I am showing the light from one direction, it is falling on both the eyes. From one direction when I am seeing, because in such a way that the light is falling on both the eyes. So, what I see is, acha theek hai, I get a normal constriction. No, reaction is normal. Now, I change the direction of my torchlight. Now, what happens? No reaction at all. Ye kaise ho gaya? One eye, one direction you are getting a pura normal and the other not at all. That is what is hemianopic. Now, why will this happen? Let us see. Why will this happen? Let us understand. We will make the diagram again very quickly because I want you to learn and make this again and again. We have learned this that okay, so this is your anatomy, nasal, temporal will not decussate, this is the lateral geniculate body, okay, optic radiations and visual cortex. Done? Yahi hai na? Okay. What we are saying? Tract lesion. We are saying there is a tract lesion. Think yourself. This is the left eye, this is the nasal retina part and temporal, this is nasal, this is temporal. When there is a tract lesion, do you realize when this is gone, that means this is not working and this is not working. Agreed or not? Iska matlab left eye temporal retina is not working and right eye nasal retina is not working. This is the reason if I am showing light, torch light, suppose my torch light is from here. Right. So, when I am showing my torch from this direction, the light is falling here and here and you are getting a normal reaction. But once I change my direction, now the light is falling on that part of the retina which is not working. This is the reason we get a hemianopic pupil. I hope this is absolutely clear to you. This is the reason in a tract lesion you get a hemianopic pupil because one eye temporal, one eye nasal is gone. Clear or not clear? Clear? Okay. Just answer this to me. Now, there is a simple question for you all and I would like you all to answer this. It is always good to be interactive. Can you tell me one thing? If it is due to one eye nasal, one eye temporal, why are we learning that hemianopic is a feature of only tract lesion? What about radiation? Here also you are getting homonymous hemianopia. What about cortex? You are again getting homonymous hemianopia. So, I will just wait if you all can volunteer and answer me this. Why is vernix we are learning for tract lesion? It can happen in radiation or cortex or not? And if yes, why? If not, no why? Tell me very quickly. Anybody would like to volunteer to answer this? Okay. So, why this is happening? Why this is happening? Because the light, when we are talking about hemianopic pupil, it is only a feature of tract lesion and not of radiation and cortical lesion. Kyun? Go back to your pupillary light reflex pathway. Talking about pupillary light reflex pathway, what do you see? That the light reflex will travel from, when you show the light to your retina, the impulse is travelling from the retina to the nerve to the chiasma to the tract. फिर क्या होता है? From the tract it is going to pretectal nucleus, and from pretectal, I will not make further, just you know this, it will go to Edinger, okay, let me draw it, no problem. So, this will go to Edinger-Westphal nucleus. You remember this or not? That means because the pathway is not going down, this is the reason that you do not get hemianopic pupil in radiation and cortical lesion. So, what do you think, what do I mean by this? Am I saying to you that in radiation lesion and visual cortex lesion, pupillary reactions are normal? Anyone? Yes or no? In radiation lesion and in cortical lesion, in visual cortex lesion, are we saying that pupillary reactions are normal? Nobody wants to volunteer to answer this? Huh? So, think yourself, yes or no? Yes. Okay. So, we make a box and write this nicely, that in an optic radiation and visual cortex, pupillary reactions are normal. Got it? Okay. What was the second thing that you learnt here? The second thing is another feature of the tract lesion. This is all optic tract lesion we are talking about. And the second thing you learnt is bow tie optic atrophy. What is bow tie optic atrophy? Think yourself that we are saying that tract lesion is same side temporal, opposite side nasal. So, in the contralateral eye, it will be the nasal fibers which are gone, and if you remember a little bit of anatomy, we have learned this, we generally learn this in the glaucoma chapter. If this is the whole retina, this is the disc and this is the macula. How does it aggregate? Because you all know na, that all the fibers from the retina is going to come to the optic disc, become the optic nerve and then exit out from the eye into the brain. So, into the orbit and further. So, the fibers from the macula travel straight, this is papillomacular bundle. Fibers from the nasal part are these, okay. These are called superior radiating fibers and these are inferior radiating fibers. And the fibers from the temporal will curve like this around the macula, and these are what? Arcuate fibers. Arcuate fibers of temporal are entering the disc from above and below, okay? But the nasal fibers are almost going straight. This is the reason for this bow tie atrophy, because this is the part which is being affected here, okay? So, this is a feature of optic tract lesion. Hope you understood about this. We next talk about what next after tract? Lateral geniculate body. Very quickly, LGB lesions, mainly it is asked in INI-CET exams. So, when you talk about LGB, you should know the structure first, that LGB is divided into 1, 2, 3, 4, 5, 6 layers, right. So, these are the 6 layers, 1 and 2 is called magnocellular and 3 to 6, this is 3 to 6 is parvocellular. And can you see the in between the interlamellar space, this is what is called coniocellular. Just remember, coniocellular is responsible for the blue color, parvocellular is responsible mainly for the color vision red and green. These are important points and they can ask you, okay. Yeah. And of course, magnocellular with the gross movements and depth perception and so on. Anyway, so once you know this, then they have asked you about the innervation. So, we have to learn this, that this 146 has contralateral supply, the layers have contralateral supply, and 2, 3, 5 has ipsilateral supply. This is one thing they ask you. And then comes another important question is on the lesions in the LGB. So, lesion in the LGB, so this is important. If you look at this one, when this horn area, all the color coding is already there in front of you. So, when this is damaged, what happens? It is happening due to anterior. So, when anterior choroidal artery is blocked, let us learn like this. If anterior choroidal artery is blocked, this is what it is supplying. Okay? It is supplying this and this, okay? This area. But if lateral choroidal artery, posterolateral choroidal artery is blocked, it is mainly supplying this area. So, the question was asked for blockage of posterolateral artery. Let us have a look. When this area is blocked, this is supplied by posterolateral choroidal artery. So, posterolateral choroidal artery, when this is blocked, what is this field defect? Keyhole visual field defect. So, this is a scotoma we are talking about. So, the question of your exam was, this is seen in, you will just answer LGB lesion, that is it. If you want to know little extra, if the anterior choroidal is gone, this area will be gone, correct. So, this is called quadruple sectorinopia, okay. So, this becomes your quadruple sectorinopia. Okay. So, that was the LGB lesion. The main question, just remember, keyhole visual field defect is due to this, and it is due to, again revise with me, blockage of lateral choroidal, okay, lateral choroidal artery. That is it. This is asked. Then next thing that they can ask you, of course, this was your LGB lesion. What next we will talk about? Of course, I am going to talk about keyhole vision. This was keyhole visual field defect. Wait a minute. First, we will, after your LGB comes your radiations. When you talk about radiations, we just said some fibers are going through temporal. We will learn the fibers which are going to the temporal lobe are inferior fibers, and because they are inferior fibers, there will be superior quadrantopia, and this is what is called, this is also exam question, we call it pie in sky, right. And if vice versa from parietal lobe lesion, if there is a parietal lobe lesion mainly through the parietal lobe, it is the superior fibers which are going. So, I hope you all know the fibers which are inferior here, what do you call them? This is Mayer's loop, and what do you call this one? We call it Baum's loop, isn't it? Baum's loop. So, when there is a lesion here, now what you get is inferior quadrantopia, right. So, inferior quadrantopia. So, inferior quadrantopia is also called, sorry, let me write here, inferior quadrantopia is also called pie in floor, right. So, inferior quadrantopia will also be called pie in floor. Okay? So, this was about radiation, but when you go more posterior, it becomes homonymous hemianopia, do not forget that, right. Okay. So, there are two things you will learn for more posterior. One, I want you to learn for posterior parietal lesions. It becomes congruous homonymous. So, now we have not discussed this, we forgot to discuss what is congruous and incongruous, right. Homonymous hemianopia, and we also get defective optokinetic nystagmus. Okay, you all know what is optokinetic nystagmus? It is a physiological nystagmus in your eye. If you are sitting on a moving train, another train is crossing you, you are sitting at the window. Do you realize you see every passenger like this, this one. So, what is this? This following movement is your pursuit and refixes secadic, pursuit, secadic. So, this is secadic and pursuit movements are optokinetic nystagmus. So, that gets affected in a parietal lobe lesion when it is posterior lesion. Okay? Just abhi ke liye I cannot go into details of that, we will just learn this much at this point. Okay, before I go further, what about congruous and incongruous? Do you realize? Congruous is symmetrical, incongruous is not symmetrical, asymmetry. Okay? So, congruous means in continuity, incongruous is not in continuity. So, if the fibers are all terminating into a small area of the visual cortex, and okay, posterior parietal and then goes into the visual cortex. these optic radiations posteriorly and then it will go to visual cortex, right. So, now the area is limited. So, any lesion, it is a continuous, it is congruous. Anterior to this, all the lesions where we have talked about tract lesion, we are talking about this pine sky, pine floor, all these we were talking about chiasmal lesion, these are all incongruous. They may not be symmetrical, they can be incongruous, just remember this much. Okay? So, that was about your these lesions. We will first next talk about what is this. Of course, this needs a mention here, visual cortex. Just remember, when you talk about visual cortex, you have learned that visual cortex, what you get is a homonymous hemianopia. Okay? Okay. Now, what we will learn further, that visual cortex is supplied by two arteries, posterior cerebral artery and middle cerebral artery. M for M, middle cerebral supplies the macular area. This is the reason when their posterior cerebral artery is blocked, what I get here, macula will be spared. Can you see the macula is spared and this black part is the one which is gone. So, what is this called? Macula sparing homonymous hemianopia. We will remember this. So, this is what is also called, pay attention, keyhole vision. This time not visual field defect, this is keyhole vision. So, keyhole vision is a feature of occipital lobe lesion, visual cortex lesion, posterior cerebral artery occlusion. But visual field defect, keyhole visual field defect, this is a feature of lateral geniculate body lesion. I think this is clear now. Okay. What about the macula? Suppose the MCA is gone. Interesting thing is, this macular is a VIP area, we all know that. So, it has some branches of PCA is also supplying this area. So, whenever middle cerebral is gone, it is never total macular, because some branches of PCA are there. So, what is the condition where I can get total macular, something like this which I have drawn for you? This can only happen when there is a trauma to the tip of the visual cortex, remember. So, macular homonymous hemianopia, complete macular homonymous hemianopia, you are going to get when there is a trauma to the tip of the visual cortex. Is it clear to you all? Yeah. So, these were the important points, and again if you look here, again it is again macula sparing, this is spared, macular area is spared, right sided macula sparing homonymous hemianopia. Okay. So, now I think you understood and you have learnt along with me what are the things that you have to remember regarding lesions. And going back to the basics, do not forget the coordinates of the retina are opposite to the coordinates of the visual field, right. So, if you remember this, then you can remember everything. So, I hope you enjoyed the session. Do you want me to revise very quickly? So, either number 1 lesion would be ipsilateral blindness, chiasmal lesions, do not forget central chiasmal, anterior junction syndrome, posterior junction syndrome, do not forget seesaw nystagmus. Then we talked about tract lesion, we will remember vernix hemianopic pupil is asked in the exam, right. What next? Then we talked about the which is the lesion which is only heteronymous, the lesions are chiasmal lesions, rest all are homonymous. You should also remember about congruous and incongruous. As I said, when you say, let me draw a line here for you. So, everything with anterior to this is, and anterior to this is what? This one becomes incongruous lesions, not symmetrical, and here this becomes congruous lesion. This way you can remember. Okay? Okay. And then of course, we talked about LGB lesion, you have to remember keyhole visual field defect due to the blockage of lateral choroidal artery. Then we talked about visual cortex, about macula sparing homonymous hemianopia and macula homonymous which happens due to trauma to the tip of the visual cortex. And of course, optic kinetic nystagmus, I hope you know what are saccadic and pursuit movements. So, if there is a defect, there can be a possibility of defective optico-kinetic nystagmus in these lesions. Which lesions? Posterior parietal, right. And of course, these questions have been asked, temporal lobe lesion, pie in sky and parietal lobe pie in floor, right all of you? Great. So, thank you so much, stay blessed and keep smiling.